Our CAT paper looked at the effects of low-intensity blood flow restriction training on quadriceps strength and knee pain in subjects with signs and symptoms of knee osteoarthritis. Our clinical scenario looked into patients with knee osteoarthritis, which affects 45% of adults within their lifetime, affecting women more than men, especially after the age of 50. Osteoarthritis may contribute to musculoskeletal deficits, as well as functional impairments and musculoskeletal pain. And then for knee OA, quadriceps strength has been linked to prevention and management of it. And to increase the quadriceps strength, it has been recommended that there is a greater than 65% 1 rep max load used during exercise, but this places a lot of stress on that knee. Blood flow restriction may be a good option to increase quadriceps strength while also decreasing stress on the knee, allowing for overall reduced knee pain. So our clinical question is, does blood flow restriction paired with low intensity resistance training, which is about a 30% 1 rep max load, decrease pain while producing similar muscular strength adaptations in comparison to resistance training alone, which is that greater than 65% 1 rep max load in subjects with signs and symptoms consistent with knee osteoarthritis? For our search strategy, we use the PICO method. Our patient and client group consisted of subjects with signs and symptoms of knee osteoarthritis. Our intervention included low-intensity resistance training paired with blood flow restriction training on quadriceps strengthening and knee pain. We compared that to resistance training without blood flow restriction on quad strengthening and knee pain. And then for our outcome measures, we looked into WOMAC, knee injury and osteoarthritis score, or KOOS, and the NPRS for pain ratings. And then for strength outcome measures, we looked into isometric dynamometer measures as well as a 1 rep max test for knee extension for the strength of the quad. And sources of evidence searched, we searched Google Scholar, PubMed, and OU Article Plus. Our inclusion criteria for this CAT paper were studies involving low intensity blood flow restriction training, subjects with signs and symptoms of knee osteoarthritis, which included knee pain, stiffness, functional impairments, aching, and quadriceps weakness. Studies that use the WOMAC, KOOS, or NPRS to assess knee pain. Studies that use a dynamometer or a 1 rep max test to assess quad strength. They were all of level 1B evidence, and they were limited to the past 10 years. And then for our exclusion criteria, these were subjects without osteoarthritis, or they had other knee pathologies. They didn't use blood flow restriction training. Studies that also didn't use the WOMAC, KOOS, or NPRS rating scales for knee pain, and studies that did not use a dynamometer or 1 rep max test for strength, and then studies that were pilot studies.
When searching for articles, we identified 6 potential studies. However, only 3 studies met the inclusion and exclusion criteria that was listed previously. The results are in the table on the right. They were all randomized control trials, and they were all of level 1B evidence, and the results will be discussed later. This slide further breaks down the 3 studies that we investigated for this CAT presentation. This slide goes into the participants of each study, the intervention investigated, and the outcome measures. The 2 outcome measures that we were concerned with in regards to our topic was quadriceps strength and knee pain. Quadriceps strength was measured via 1 rep max and dynamometers, and pain was measured via the NPRS questionnaire, the WOMAC questionnaire, and also the KOOS questionnaire. And every measure was measured in the beginning and post-treatment in each study. This slide is a continuation of the previous table, however, focuses on the main findings, the level of evidence, the validity score, and the conclusion of each study. When looking at BRIKE, the main finding was that blood flow restriction training showed similar adaptations in knee osteoarthritis patients while decreasing pain during exercises, but not after. In Ferreira's, the main finding was that blood flow restriction training showed similar adaptation while decreasing pain in knee osteoarthritis subjects. And in Segal, the main finding was blood flow restriction training improved quadriceps strength in those with signs and symptoms consistent of knee osteoarthritis. The statistical breakdown is listed below the main findings. All the level of evidence was level 1B because they were randomized control trials, and the validity scores were very similar. Ferreira's and Segal were missing randomized control trial in their title, and other things that were missing were things such as who funded them and who they reported to. Bright's conclusion was that low load strengthening associated with blood flow restriction showed the same improvements in strengthening and pain relief, however, did decrease pain during exercise. Ferrer's conclusion was that blood flow restriction training and high intensity resistance training showed similar strength adaptations. However, blood flow restriction training was able to improve pain. And finally, Segal's conclusion was that blood flow restriction resistance training was effective in increasing leg press and knee extensor strength in women with signs and symptoms and risk of knee osteoarthritis, however, had no significant improvements of pain. There are a few things we would like to discuss about our articles that we found. First was pain measures. So in some of the articles, participants did drop out due to pain while exercising. However, all the participants that dropped out due to pain were in the conventional resistance training groups, not the blood flow restriction groups. So this could show that blood flow restriction training does decrease load on the knee and therefore decrease pain. Also, we feel like pain is very subjective, and depending on how severe their signs and symptoms were or how long they were with their knee osteoarthritis, it could have affected their results. The next thing we'd like to discuss is the generalizability. So this studies that we looked at only looked at elderly women with signs and symptoms of knee osteoarthritis, so it isn't very generalizable to men or other ages or other conditions. The overall results, we feel like if properly used and properly trained, blood flow restriction training is a safe and effective alternative training method in elderly individuals with signs and symptoms of knee osteoarthritis. And finally, the future research we think needs to be done is a similar study design of the ones we found, but for males. Studies looking at other musculoskeletal diseases and the effects of BFR training, and also long-term pain ratings in individuals with signs and symptoms of knee osteoarthritis who perform blood flow restriction training. Our clinical bottom line is that there is strong evidence supporting that low-intensity blood flow restriction training produces similar muscular strength adaptations while potentially decreasing pain in an elderly population with signs and symptoms consistent with knee osteoarthritis. We think that blood flow restriction training has the potential to decrease pain, however, due to the varying evidence, it should be investigated further.